Welcome to This Explainer. Today, we're diving straight into a real clinical mystery. Why do so many newborns turn yellow? Now, if you've ever spent any time in a maternity ward, you've almost certainly seen it. It's one of those things that can instantly panic new parents, but as we're about to see, it's actually a completely fascinating biological process. Today, we're going to put on our medical detective hats and figure out exactly what is happening inside a newborn's body to cause this. And we're starting off with a statistic that honestly blew my mind.
So ask yourself, why do up to 70% of perfectly healthy newborns suddenly take on this yellow hue within the very first week of their lives? Just think about that for a second. More than half of all babies born go through this visible physiological shift. Before we hit you with all the heavy medical science, it is absolutely crucial to establish just how incredibly common this condition is.
Yep, 70%. So if you're a parent and you've experienced this, you are firmly in the majority. Up to 70% of babies develop jaundice in their first week. I really want to reassure you right out of the gate that this is incredibly prevalent, and in the vast majority of cases, it's just a perfectly normal adaptation to life outside the womb. But what exactly causes it?
Well, here's our roadmap for today. We're going to cover what neonatal jaundice actually is, track bilirubin's path through the body, compare physiological versus pathological cases, dig into the main causes, and wrap up with diagnosis and treatment. Let's get right into it.
What is neonatal jaundice?
So, jaundice isn't actually a disease itself. It's a syndrome, and it's caused by the accumulation of a substance called bilirubin in the blood and tissues. It's this buildup that literally turns the skin, the mucous membranes, and the sclera, the whites of the eyes, yellow. What's really fascinating here is that the intensity of this color is a direct visual indicator of what's happening inside. Depending on the specific bilirubin levels, a baby's skin can range anywhere from a pale light lemon color all the way to a dark olive green.
Moving to part 2, bilirubin's path in the body.
To really understand when and why things go wrong, we first need to look at what normal looks like by following the journey of a single red blood cell. It's basically a complex, 4-step biological assembly line. Step 1, red blood cells break down. When just 1 single gram of hemoglobin breaks down, it creates 35 milligrams of toxic hydrophobic bilirubin, specifically a type called the IX-alpha isomer. Now, because it's hydrophobic, meaning it repels water, it is highly toxic and the body can't just excrete it as is. So step 2, it binds to a transport protein in the blood called albumin, which safely escorts this toxic package over to the liver. Step 3, the liver acts like a chemical processing plant. It uses an enzyme to conjugate the bilirubin with glucuronic acid, which finally makes it water-soluble. And step 4, it's safely excreted through the bile right into the intestines.
Which brings us to part 3, physiologic versus pathological jaundice.
Okay, here's the massive sigh of relief. 90% of all neonatal jaundice cases are purely physiological. It's literally just the newborn's immature liver playing catch-up with the massive breakdown of fetal red blood cells. Totally harmless. However, that remaining 10%, that represents pathological jaundice, and that is a true medical threat that requires immediate intervention to prevent long-term damage.
Now, doctors can actually track this severity without even waiting for an immediate blood test, using a brilliant system called Kramer's rule. It's a literal top-to-bottom visual alarm. The yellowing always starts at the face, in zone 1, which corresponds to bilirubin levels around 31 to 136 micromoles per liter. But as toxicity rises, the color spreads downwards, to the chest, then the stomach, the knees, and finally reaching all the way to the hands and feet in zone 5. If it reaches the hands and feet, that indicates extremely dangerous levels exceeding 255 micromoles per liter.
Let's quickly compare these two to build out our clinical understanding. Physiological traits are harmless, right? They usually show up a bit later, like around the 3rd day of life, and they just resolve on their own. Pathological warning signs, though, are alarming. They have an early onset, often within the first 24 hours, and they feature severe, rapid spikes in bilirubin. The ultimate danger we're worried about here is bilirubin encephalopathy, because if those toxic, unconjugated molecules detach from their albumin transport and cross the blood-brain barrier, they can cause irreversible neurological damage.
All right, part 4, the main causes of pathological jaundice.
So what exactly causes that dangerous 10%? Well, our first culprit is massive overproduction, primarily from hemolytic causes. This happens when the baby's red blood cells are being destroyed at a terrifying rate, completely overwhelming the liver. This can be due to maternal immune conflicts, like an Rh or ABO blood type incompatibility between the mother and fetus, Or it can stem from genetic defects in the blood cells themselves, like Minkowski-Chaufart's disease where the cells are too fragile and spherical, or a lack of the G6PD enzyme, which is supposed to protect red blood cells from breaking down. Now, if overproduction isn't the issue, our second suspect is clearance failure. Here, the blood cells are totally fine, but the liver's processing plant is basically broken. This includes genetic conditions like Crigler-Najjar or Gilbert syndrome, where the liver is literally missing the critical glucuronidase transferase enzyme it needs to make the bilirubin water-soluble. We also see this in endocrine issues like hypothyroidism, or even, interestingly enough, due to specific hormones and free fatty acids found in breast milk that can temporarily inhibit liver function.
And finally, we have our third category, mechanical blockages. In these cases, the liver works perfectly. It successfully processes the bilirubin, but the exit doors are glued shut. The water-soluble bilirubin gets physically trapped in the bile ducts and spills right back into the bloodstream. We see this in severe structural anomalies like biliary atresia, physical obstructions like bile plug syndrome, or thick mucus blockages caused by mucoviscodosis, which you probably know as cystic fibrosis.
Let's look at Part 5, Diagnosis and Clinical Signs. With all these different suspects, overproduction, liver failure, mechanical blockages, how do doctors actually crack the case and find the exact culprit? Well, they look for very specific physical clues. In hemolytic jaundice, that massive breakdown of blood causes early yellowing, but because the liver is still managing to push some processed bilirubin into the gut, the baby's feces and urine stay a normal color. But mechanical signs are totally different. If the bile duct is blocked, zero pigment reaches the gut. That results in achylic, completely colorless, white feces. Meanwhile, all that trapped water-soluble bilirubin gets filtered by the kidneys instead, causing dark, tea-colored urine. Plus, the skin often takes on a distinct olive-green hue. These are massive red flags for a mechanical blockage.
To confirm what's going on, the medical team uses some specific lab tools. They'll run a Coombs test and check blood grouping to confirm or rule out those maternal immune conflicts. Crucially, they measure the exact ratio of direct, meaning processed, versus indirect, meaning raw, toxic, bilirubin. A high indirect level points to overproduction or liver failure, while a high direct level points straight to a mechanical blockage. And of course, a liver ultrasound lets them actually look inside and visualize those bile ducts.
And finally, Part 6, Treatment and Prevention.
Once the detective work is done and they've identified the cause, it's time to take action. The entire goal here is treating that 10% of pathological cases fast enough to protect the newborn's developing brain. We generally divide treatments into two camps. Conservative therapies are non-invasive. We use medications like phenobarbital to stimulate the liver enzymes, or we use phototherapy. Then, for extreme emergencies, like severe hemolytic conflicts where the blood is rapidly turning toxic, we bring in intensive operative measures. This means exchange transfusions or plasmapheresis, where doctors literally remove the toxic blood and replace it with healthy donor blood.
But honestly, the absolute star of the show for treating most jaundice is phototherapy. It is beautifully simple and just incredibly effective. By placing the newborn under specific blue ultraviolet lights, the light energy physically hits those toxic, hydrophobic bilirubin molecules stored in the skin and literally changes their molecular shape. It turns them into a completely harmless, water-soluble form called lumirubin. This bypasses the liver entirely and lets the baby just easily pee it out. It's light literally altering biochemistry. How cool is that?
It really is amazing to see how medical science decodes the body signals. As we marvel at how the human body adapts to life outside the womb and that unbelievable transition a newborn has to make just to survive, I'll leave you with this. The next time you see a newborn with a slight yellow tint, what visual cues will you be watching out for? You now know exactly how Kramer's rule works, and you know exactly why the specific color of the symptoms matter so much. Keep your curiosity bright, and thank you so much for joining me on this explainer.